Well, of course, I mean, we started with two very important trials that have consistently demonstrated that IFR and FFR are equivalent in terms of safety when you are performing ischemia-driven revascularization. So, of course, merging the two databases will provide, since they were consistent in each of the studies, will provide basically the same observation. It's true that it got reinforced, the message got reinforced in terms that overall the safety of decision making based on IFR or FFR is equivalent, both in terms of the primary endpoint, that is MACE, but also in terms of the secondary endpoints that are death of cardiovascular and non-cardiovascular causes, myocardial infarction, and planned revascularization. So in that regard, it's true that we also obtained the plus of knowing that nowadays using IFR is as safe in contemporary scenarios like FFR. But our focus was different. We wanted to explore something that was not reported in these two trials, and that was actually the safety of deferring revascularization based on FFR or IFR. And by deferring, I mean deciding to put the patient on medical treatment because you had demonstrated that the stenosis was hemodynamically non-significant. Yes, so the study population is actually one that truly reflects the patients that we in the interventional community are interrogating with pressure guide wires. I mean, if you think about the recommendations of clinical practice guidelines, basically they speak in the text that you can use it to interrogate ambiguous stenosis or stenosis of ambiguous severity. Well, this is beautifully reflected in the FFR value distributions. The mean FFR is 0.83, very close to the cutoff of 0.80, meaning that these are intermediate stenosis. There was a mixed bag of stable angina, about 2/3, and acute coronary syndromes, always non-culprit vessels interrogated. And now the main question we wanted to address was, okay, I have a patient with acute coronary syndromes, interrogated with IFR or FFR, and now I'm told that I have not to perform PCI because I get a value that is above the cutoff value. Is it safe to defer these patients? And this is a very important question nowadays. Remember that many physicians still feel, fearful about sending home a patient with an stenosis, because if something happens to these patients, somehow they feel that perhaps they did not the right thing. They tend to follow the instinct of saying, if there is an stenosis that to me seems important, I better treat it. So it was very important to save that. So even when this is a very important part of the whole concept of ischemia-driven revascularization, this was not revisited since nearly 20 years ago, since the DEFER trial. So that was the main focus of our study. Well, the findings are very positive. The first message we have for the colleagues is that deferring revascularization based on physiology is safer than ever. So overall, the event rates that we observed at 1 year were half of the event rates that were observed in the deferred cohort of the deferred trial. So that means that over the last 20 years, the safety of deferring patients based on pressure guide wires has improved a lot. And that means that the concomitant medical treatment that we are having is, of course, playing an effect in the management of ischemic heart disease. We also found that you can take this decision as safely using IFR or FFR. That was very important because, interestingly, when you perform IFR, you treat less. You treat even less than with FFR. You perform less interventions. In other words, you defer more. So it was very important to make sure that this, say, extra deferral was associated with similar outcomes. It's exactly the same. And the third finding was very puzzling and actually was triggered by the research of other groups that have found, this is data published over the last 2 years, that in acute coronary syndromes, the safety of deferring was not as good as when you are taking it, when compared to patients with stable angina. In other words, there was the concern that perhaps decision making with pressure guide wires in acute coronary syndrome was not completely safe. So we certify now, or we concur with these researchers in that this is a fact. You have a slightly higher, significantly higher event rates in deferred patients who presented first with an acute coronary syndrome. On the top of that, we found something very interesting that points in the direction that perhaps it is not an excess of vascular risk in these patients, because actually in the treated arms there was no difference between the outcome of patients with acute coronary syndromes or stable angina. It seems to be more to the fact that you are performing suboptimal decision making with pressure guide wires. And in that regard, it seems like FFR is more influenced in terms of the outcome of patients in the long term, deferred patients I'm referring, of course, when you have a clinical presentation of acute coronary syndromes. So this is something that I believe will foster a lot of research, because although in magnitude there is not a big difference in the event rates in these two subsets, acute coronary syndromes and stable coronary disease, obviously there is room for improvement, and we should strive in providing the best solution also for our patients with acute coronary syndromes. Well, the most obvious one is to reassure our colleagues that they can safely perform deferral of revascularization in their patients using IFR or FFR, particularly in patients with stable angina or stable coronary artery disease. It is interesting that our research coincides in time with the publication 2 weeks ago of a very important paper by a French registry of stable coronary artery disease, demonstrated that in stable patients you have an excellent outcome in the long term, and actually the worrying part of it is that this less than 1% annually of rate of myocardial infarction was influenced in a significant way by late stent thrombosis. So we have to keep in mind that we can identify with IFR, FFR, patients that do not require stenting, and that stenting, just in case, introduces always an additional risk for the patient. This is basically the main message. And the second message is more directed to the, say, research community, to clinical scientists. We have to investigate more on the physiological assessment of stenosis in the context of acute coronary syndromes. I think that this study, as I say, coinciding with other research from other authors, is pointing into the direction that there is room for improvement, and that we have to look into which is the best way to ensure that we perform physiological assessment of stenosis in patients with acute coronary syndromes.